Welcome to Learning Thursdays. My name is Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled The New Normal, Technology, Telehealth, and Ethics. And our presenters today are Lisa Babb, Susan Snyder, and myself, all of the Learning and Development Unit. Susan and Lisa will be joining me in just a moment. But first, a word about Learning Thursdays. Learning Thursdays are offered to addiction professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals in prevention, treatment, and recovery services. So how did we get here? Pop quiz, Susan, Lisa. In what year and who first suggested the recording of counseling sessions?
I think it was in the 1940s, possibly. And wasn't it a psychiatrist?
Okay, 1940s and a psychiatrist. Is that your final answer?
I would say early 1960s.
Any idea who it was?
A theorist.
Okay. So it was actually, you were real close, Susan. It was actually in 1942, yes, by Carl Rogers. So with that came three waves in the advancement of technology. In 1999, experts predicted advances in technology for therapists and counselors. First, fax machines, word processors, answering machines, and voicemail machines. Second, the enhancement of test administration, scoring, and interpretation. And lastly, the use of the telephone, email, and chat rooms. Now, beyond being HIPAA compliant, we didn't have any ethical codes regarding using fax machines or voicemail 10 to 15 years ago. And now, technology in 2020. There's really been a lack of literature and research to provide guidance for the field. Now, technology may be used as part of the therapeutic exchange, but then what? How do you document using it, and what are any guidelines for the exchange? There is guidance on utilizing telepractice by OASAS providers, and it can be found at this link. There's also a reopening guidance that can be found on this link. Susan, do you have anything to add on the guidance of utilizing telepractice for OASAS providers?
Very much so, Dean, which is very important because we were put into the COVID emergency status back in March, and telepractice became very important. So on March 17th, guidance was utilized where telepractice was published for OASAS providers. And this was to be effective immediately and put into place for the duration of the COVID-19 emergency. And it notifies providers of flexibility with video conferencing technologies that they may use to provide services for their clients. The notice granted flexibility for providers with HIPAA only to a certain extent where due diligence is expected, but flexibility is also provided. This is something that our providers need to be aware of, and it would be very beneficial for them to be aware of this document.
Thanks, Susan. That's some great information. So there's also been several other updates which have included the Substance Abuse and Mental Health Services Administration, also known as SAMHSA, issued new guidance for opioid treatment programs, indicating these programs can also prescribe buprenorphine via telehealth, and they also liberalized the number of days of take-home medications, which subsequently reduced in-person visits. The Center for Medicare and Medicaid Services is temporarily waiving restrictions, which allows Medicare to actually cover additional telehealth services as needed. And finally, like Susan just talked about, the U.S. Department of Health and Human Services has announced it will waive Health Insurance Portability and Accountability Act penalties, also known as HIPAA, for the good faith use of telehealth. So at this point, many practitioners have found themselves vulnerable to really being blindsided by these new ethical dilemmas we found ourselves in. Why didn't we see this one coming? Sound familiar? We were really blindsided with coronavirus COVID-19. COVID-19 really, we know, increased the social distancing and working remotely. And we're actually working remotely. We've been working remotely since March 16th, and we'll continue to work remotely. During COVID-19's response, the provision of online treatment services has really also, though, enabled clinical staff to continue supporting people through telemedicine and telephonic services for substance abuse services. So as much as people were blindsided, there really has been as smooth as possible transitions to minimize the disruption to participants of our services. There's also been an increase in telepractice, which has removed the barriers of time, distance, and location. So the counseling profession, as it adjusts wisely to the new culture, really has to involve two things. It has to adapt an understanding of ethical principles themselves, as well as developing competency in the technology of this new digital culture. And we'll talk more about that in just a few. So with some of the platforms that you may or may not be familiar with, may or may not have utilized or will in the future, Zoom, YouTube. Today we are using Cisco WebEx. A lot of the colleges and universities utilize Blackboard or Moodle. There's Google Classroom and Doximity. And although OASAS does not endorse or promote any particular one platform, we are using Cisco WebEx today. Now, again, these are just a few. Whatever you decide to use, remember, services provided by Telehealth must be in compliance with the Health Insurance Portability and Accountability Act, also known as HIPAA. They also need to be in compliance with all laws and regulations governing confidentiality, privacy, and consent. So with that being said, privacy issues. Just last week, a video conference site experienced widespread outages with users not only in the United States, but also in the United Kingdom, reporting problems joining video calls. Zoom hackers, otherwise known as Zoom bombers, last Tuesday actually gained access to a meeting between Columbine High School teachers and parents in Littleton, Colorado. And they were shown inappropriate graphic photos and unfortunately were subject to verbal threats.
Today we're going to discuss digital types in this segment. But prior to introducing two digital types, I'd like to make a little disclaimer. These terms are based on age and several other categories that I'll mention toward the end of the segment. The information presented in the section highlights the terms digital native and digital immigrant. Both these terms were coined by Mark Prensky. Prensky's work is based on observation rather than research, and was written to highlight problems in the education field. Since he first coined this phrase, digital immigrants and digital natives, much has been written to refute his observations. Digital immigrants were people born about 1964 or before, and who grew up in the pre-computer world. There are also digital natives, so to speak, digital speakers of the digital language, native speakers of the digital language of computers, cell phones, video games, and the internet. Some people refer to these as people as being born with DNA running through their veins. The young child in the supermarket that plays on the smartphone. Here's a comparison of digital types. Digital immigrants prefer to talk to people in person, one-on-one, or on the telephone. They tend not to text or use sparingly, only perhaps to confirm an appointment. Digital immigrants prefer live communication, prefer receiving information slowly, linearly, logically, and sequentially. They prefer reading books, processing pictures and sounds and videos, whereas the digital native prefer to talk via chat, via text, or messaging through social media. They prefer to text more than call. The digital natives prefer asynchronous communication, as you just explained, and preferring receiving information quickly and simultaneously from multiple multimedia sources. Many digital natives prefer processing, interacting with pictures, graphics, sounds, and videos, much more so than reading a book and especially holding a book in their hands. Other digital types. I had mentioned before that this study, the digital immigrant digital natives, was based on age, but they also take into consideration attitude. How might your attitude toward technology play a role? And the comprehension. There's a fear, intimidation of technology, which as you build a relationship with technology, people are leery. There's a fear of the numerous scams that are out there. So, but practice and becoming comfortable with technology definitely helps. There was a study done. Younger clinicians and those with smartphones find apps, for example, more usable than older clinicians and those without smartphones. These variables often predict a clinician's intention to use apps in treatment. For example, the PTSD apps with veterans. A study was done in 2014 that involved veterans using PTSD apps, and the veterans really took to the apps and enjoyed working on them and felt they were very user friendly. And on the flip side of that, though, the older clinicians that did not have experience with smartphones did not feel that the apps were very usable or user friendly.
Yeah, Lisa, if I can, that's a great point. With the advances in technology, there's been some challenges, but there also has been the development of some great resources. And we've always heard in the field, we want to give people as many tools in their toolbox as we can. And there's a lot of apps out there, and it's a great resource and great opportunity, again, to give the participants of our services some more tools in the toolbox. So that's great.
Absolutely. And there's a lot of 12-step meetings on Zoom now.
Right.
There's a lot of health improvement apps that count your steps, that can take you from they call it a couch potato to a 5K, which is 3.1 miles. So there's so many things that people can engage in and become involved. The YouTube's do-it-yourself videos. So it's really nice if people are willing to take that first step. And in some ways, that was a benefit from working remotely.
That's a great point. You bring up mutual aid sober support meetings. When this all happened, a lot of the in-person meetings were suspended for, good reason. But the benefit now with the online meetings that was not there so much as before, not as many, is you have rural communities that may have, one meeting a day or 2 or 3 meetings a week, where now with these mutual aid sober support apps, regardless of where, someone is in a geographical location, they can get on and really have access to meetings, in a much greater sense, where only if someone lived in, a larger area, a bigger city where there's daily meetings and sometimes 3-4 meetings a day, they wouldn't otherwise have that access.
This is another little study that was very interesting. As of July 2020 in New York State, the average age of a CASAC is 53 years old.
Wow.
Now let's think about the opioid epidemic that's going on right now. And that is hitting a lot of younger people very hard. And there's also, not to minimize the use of prescription drugs in older adults, or misuse, abuse in older adults, or the opiates in older adults, but there's definitely a large percent that are the age of 40 or under, 40 years old or under, who are seeking to receive substance use disorder services at this time. And that's something to take into consideration when people are resistant to using the applications or Zoom or video like we're doing right now, that there may be some resistance, but it's also to meet the needs of our clients that are coming into the field. I came into COVID and social distancing and whatnot, definitely as a digital immigrant. And for survival purposes, I've become able to do Zoom, to do WebEx, to figure out how to clean out a computer to put other things in that I need for work. So it's really amazing, and things that I thought I would never do because of my own attitudes toward technology and intimidation by technology, I've moved past. So hopefully other people will also be able to step forward. Shoot, like I said, my mom, 86 years old, is moving forward. So as we speak about go into the next segment of social media, Susan Snyder will be talking to us and sharing about that.
Social media. Social media is a broad term that refers to online forms of communicating that any individual can employ, as opposed to industrial media, which refers to professionally produced radio, television, and film. Now, what this slide is presenting and wants you to know is the fact that anyone can post anything on the social media sites, whether it be poetry, their own opinion, or statistics. When posting a patient narrative on social media, it's important to use a stop and think approach, because writing a de-identified patient narrative using a respectful tone on a blog or other social media site, similar to narratives published in books and medical journals, is not itself wrong. However, it is the platform of digital dissemination that threatens to render the details identifiable. And when posting information about a patient or a narrative on a social media site, it's important to remember that patients consider it a breach of confidentiality if they can recognize the patient from the site. Sharing patient stories of a personal nature, even if positive and with the best of intentions, may be perceived by viewers as encroaching on patients' personal boundaries, thus carrying some inherent risk to the public and to the profession. Even if the narrative is of a positive nature, a patient will feel that there's been a breach of confidentiality and a betrayal of trust in relation to their therapist or clinician. Now, a social network site is a website that provides a venue for people to share their activities with family, friends, and colleagues, or to share their interest in a particular topic. And a good example of that is Facebook, Google, LinkedIn, and Twitter. Social network sites are a specific type of social media that allow individuals to construct a public or semi-public profile within a bounded system, articulate a list of other users with whom they share a connection, view and traverse their list of connection and those made by others within the system. One of the sites that come to mind is Facebook. People post on Facebook all the time, vacations, interest, recipes, much personal information that is shared on a very public level. Examples of those social network sites are Facebook, Instagram, virtual worlds, and counselor listservs, things to be aware of. Since patients are likely to use social network sites, it may be helpful for practitioners to understand the social network phenomena, even if they do not participate themselves. As a clinician, one has to understand that our clients and patients may be very interested in social network sites and use them, and the clinician may not. but they have to understand that this is something that the client is interested in and will use.
Yeah, Susan, that's a great point. We've also always heard about patient-centered care and meeting people where they're at. And regardless if a clinician is personally, a fan or not a fan of these social networking sites, a lot of the participants of our services now are. So again, keeping in mind patient-centered care and meeting people where they're at, it's really necessary to become well-versed in this platform.
Yes, that's true, Dean, very much so. Now, these are ethical issues and guidelines for counselors' self-disclosure when using social network sites. There are ethical codes and technology rules to abide by. Ethics and self-disclosure. Self-disclosure is a very important topic for a clinician. Self-disclosure definition and guidelines. Rural examples. Ethical guidelines for social media from different disciplines. Suggestions for postings to social network sites, and liability insurance for social media. Now, ethical codes and licensing boards have not caught up with the technology in some cases. However, there are some boards that are caught up in technology, however, not all. One site that is caught up and with ethical codes, is the National Association of Social Workers. However, all sites are not up to date and current, and it's important for the clinician to stay on top of their governing site and their oversight agency and to know what their rules and expectations are. Now, the 5 ethical principles, these are 5 moral ethical principles to guide us. Non-maleficence, to do no harm. Autonomy, clients get to make their own choices. Beneficence, to do good. Fidelity, to keep promises. To justice to be fair. And there are 2 other that are often included in this, veracity and obedience. Now, these were listed by Kitchener back in 1984. Ethical reasoning. These are 8 rules by Sternberg as a guideline for behavior to define it. For moral and ethical reasoning. Number 1, to recognize there is an event that prompts a reaction. 2, to define the event as having an ethical dimension. 3, decide that the ethical dimension is of sufficient significance to merit an ethics-guided response. 4, to take responsibility for generating an ethical solution to the problem. 5, to figure out what abstract ethical rules might apply. Number 6, to decide how these abstract ethical rules actually apply in order to suggest a concrete solution. And 7, to prepare for possible repercussions of having acted in what considers an ethical manner. And number 8, act. And these are Sternberg's rules for defining behavior. And defining behavior is very difficult. Now, there are several boards that use existing laws and investigate complaints based on the grounds of unprofessional conduct, unethical conduct, moral turpitude, mismanagement of patient records, revealing a privileged communication, and a breach of confidentiality. Now, OASAS oversees CASAC credentials, and there is a committee, an investigating committee that investigates CASAC complaints. And this individual's revocation of their credential was based on personal emails. The personal emails documented and was proven that there was an involvement with the patient outside of the boundaries of the, and this is also defined by the CASAC canon of ethics. So this individual, as you see, lost their credential. It was revoked based on the investigation. In 2013, the Justice Center came into existence in New York State for the protection of people with special needs, and it's still in existence today. Now, the New York State Department of Education acts on professional misconduct and discipline that applies to social workers, licensed mental health counselors, nurses, psychologists, and more.
So Susan, if I can just ask for a little clarification. So if I'm hearing you correctly, if a clinician holds a CASAC credential and they're also an MSW, if they get brought upon an investigation for an unethical act, they could essentially be investigated and found and penalized by two different oversight agencies for one ethical issue?
Correct.
Wow.
The canon of ethics for the CASE Act defines behaviors, and for social workers, the New York State Department of Education is their oversight. Now, healthcare professionals can use social media for many things, as Lisa stated. They can put information out there that will potentially improve health outcomes, such as nutrition, to assist in developing a professional network, to increase personal awareness of news and discoveries, to motivate patients, to provide health information to the community through the internet and resources. It's invaluable. There's a wealth of information to be had. They can also share information, debate healthcare policy and practice issues, promote health behaviors, engage with the public, educate and interact with patients, caregivers, students, and colleagues. And these tools are a great resource because they are used to improve or enhance professional networking and education, organizational promotion, patient care, patient education, and public health programs, and present potential risks to patients and healthcare professionals regarding the distribution of poor quality information and damage to professional image, breaches of patient privacy, violation of personal professional boundaries, and licensing or legal issues. One needs to be aware of what's being posted on the internet and on the social network sites. And with that, I would like to turn you back over to my colleague Lisa for counselor self-disclosure.
Counselor self-disclosure. Self-disclosure in psychotherapy is defined as the revelation of personal rather than professional information by a psychotherapist to a client. We will also use the term psychotherapy and psychotherapist in regards to a CASAC. Counselor self-disclosure has an impact on the clients. It may be benign, which is the normal parts of human existence and relationships that may have significant clinical significance. It could be deliberate or non-deliberate or avoidable, unavoidable self-disclosures such as accent, skin color, mannerisms, or office decor are those that the clinicians may need to consider. As we know with Dean, as you see him, he has pictures behind him. I too have pictures as well as Susan. Now we need to be aware, are they family pictures? Are they something we prefer clients not to see? This is something that is new for during this new dilemma.
Oh, I see what you mean, Lisa. What you mean is we're broadcasting from our home environment as opposed to our office environment, and we could have pictures up of our family members, which we may not want anybody to see.
Right. Now that would be a benign self-disclosure because it's not intentional. It would do no harm. When it becomes family photos, you would, depending on your setting, you want to be a little bit careful. At least that would be my suggestion. I've worked in the prison system, as so have you, and I was very careful not to have any pictures of family or anything. I kept everything very neutral. The next is appropriate self-disclosure. which is ethical and clinically driven self-disclosures that can occur when with the client's welfare in mind and with a clinical rationale behind it. What are your motives in making the disclosure? You want to ask yourself also throughout your career, your counseling career, what are your motives when you ask questions? What are your motives to having certain things in your office? The inappropriate and unethical self-disclosures. This is where counselors and social workers and others that are licensed get into trouble. A counselor sharing personal feelings about an intimate partner relationship to gain the client's empathy or support is not acceptable. That is an inappropriate disclosure. If a counselor reveals an attraction, a physical sexual attraction to a client, that is inappropriate. If a counselor texts inappropriate pictures or sayings to clients, that is inappropriate.
And it does happen because when I worked in regional field office, there was an individual that sent intimate pictures to a client, and he was a counselor, and he ended up losing his credential because it was proven with the record.
And absolutely, thank you, Susan. And when we further on in this training, Dean is going to speak on the amount of time that texts are held in the phone or emails are held in a cell phone. And you may be quite surprised. I know I was. In rural areas and social network sites are characterized by pervasive incidental contact, inevitable self-disclosure, unavoidable multiple relationships. There are several types of rural dilemmas that involve multiple role relationships, overlapping social relationships that I just spoke on, not only social, that was social and employment business. Also, overlapping professional business relationships. A counselor may also be the coach of the Little League program, or the counselor may be one of the counselor's clients, may be the coach of their child's Little League team. So things can get very enmeshed in smaller areas, in more rural areas. Technology has redefined the process of counselor self-disclosure. We spoke about Facebook. We spoke about texting. This is all new. Many social network users are communicating in their virtual underwear, so to speak, with few inhibitions. There's GPS on the phone. People turn on the GPS so family and friends can see what restaurant they're at, or they may take a picture. Well, that is sent out over the airways. If I send it to Susan, who sends it to Dean, who sends it to one of his Facebook sites, not only do Susan's friends, Dean's friends, and whoever his friends are now knows where I'm having my dinner with family and friends. So it's a big world. Social networks sites are a big world, and when they say that you're communicating in your virtual underwear, it means you're putting yourself out there. There's a need to examine your personal use of social network sites outside of the therapy hour and its impact on your reputation and credibility. As previous stated, be aware of what you post, of what you say. Ask yourself, should counselor therapists participate in social network sites as a private citizen? This is something that you need to consider for yourself, and you may want to bring to supervision also. Questions to ask yourself before posting. What are the costs and benefits of posting the information? Is there a high probability that clients will be significantly and negatively affected. How will the disclosure affect my relationship with my clients? How does the disclosure threaten my credibility or undermine the public's trust in the field of counseling? These are all things to really think about before you hit that send button or that post button. This is one of my favorite rules. Follow the elevator rule. If you wouldn't say it aloud in a crowded elevator, don't post it online. Counselors should not post client information. Counselors should not post disparaging comments about colleagues or client groups or clients. Counselors should not post unprofessional media, photographs, videos that undercut the reputation of the psychological practice or of themselves. It's something to think about. Go back to the example of sending to Susan, who sends to Dean, who sends the video further on or the picture further on. Counselors should not post comments about litigation in which one is involved. That has to do with divorces, legal cases, possible investigations of governing agencies. So there's a lot that really needs to be thought about for a counselor.
Yeah, Lisa, this is great advice. So, here's a tip. If you have a bad day at work, don't go home. Hop on social media and post about it. Once you hit that click button, it's there.
Rants cannot be recalled. For giving more information regarding emailing, texting clients, privacy and security, and I will hand you over to Dean.
So emailing and texting clients, privacy and security. Security of email, or lack of security for that matter. Emails are stored at multiple locations. The sender's computer, obviously, if you send an email and then you go into your send box, you'll see it there. Your internet service provider's ISP server and the receiver's computer. So it's important to remember, deleting an email from your inbox does not mean there aren't multiple other copies still out there. Emails are also vastly easier for employers and law enforcement to access than phone records. Self-disclosure, one of my guilty pleasures is watching the A&E series, The First 48, and it never fails. The homicide detectives, love it when they can get their hands on a computer because they can almost instantly access those emails that were sent and received, as opposed to phone records, which take a little more time. Finally, due to their digital nature, they can be stored for very long periods of time. I'm gonna age myself right now. So remember, email is not like mailing a sealed letter or package. It's more like sending a postcard. People aren't supposed to read it while it's in transit, but it passes through many hands, and one can never be sure that someone's not reading it illegally. So there are HIPAA rules regarding email. The privacy rule. It allows providers to communicate electronically with patients. There needs to be reasonable safeguards, including checking the email for accuracy, sending an email alert, and also limiting the amount or type of information disclosed. This goes back to sometimes less is more. And of course, and as always, it has to be in compliance with 45 CFR, Part 164, Subpart C. Healthcare providers can provide email reminders to patients if the patient has given their consent. So for example, I was at my primary care physician's office the other day, and they asked if I wanted them to send me an email reminder for the next appointment. I said, yeah, that's great. I had to sign a consent. So now I'll get a text message or email so I don't miss my follow-up appointment. And lastly, patients can initiate email communications with providers using their email. Here's a fun fact. More than 1/3 of cell phone users, in particular 38%, have sent a text message to the wrong person. 37% report that a text they sent was misunderstood by the reader. And it's very hard to interpret any sort of emotion or tone from a text message, and it's easily misunderstood. You know, there is some email and text messaging etiquette, which some people may or may not be aware of. For example, you know, capital locks, I guess, is supposed to mean that someone's yelling or screaming. So here's a couple funny examples, or not so funny examples, of texting miscommunications. Love you, babe. Good night. My love for you is strong. I'd buy you a casket if I could. Autocorrect. That's supposed to be castle, not casket. Text messages can be saved, sent to an email account, and posted online, all without the other person's permission. So I'll give you an example. I text Lisa something today. She can save it. She could take a snapshot, or she could forward it to her email account. She could post it online. She could send it to Susan's email account. She could take a snapshot. She could text it to Susan. Susan could then post it online without my permission, without Lisa's permission, could post it on social media. Then not only, Susan has it on her Facebook page, she may tag me in the post, may tag Lisa in the post, and it just goes on. And before you know it, the initial text message that I sent to Lisa, and only Lisa, is out there with who knows how many people seeing it.
And Dean, that would be without your knowledge. We could do all this. Absolutely. Without even your knowledge. And that's the scary thing, the frightening thing.
Absolutely. I could find out the hard way when, down the road, a friend of Susan's emails me or calls me at work and says, hey, wow, this is really interesting. I got a text message copied or sent to me in an email. And that's if somebody let me know. I could never know the hundreds, if not thousands, and unlimited numbers of people that have access and seen that text that I really just wanted you to get. Good point, Lisa. Susan, don't do that. Let's talk about perpetual texters. Yes, adolescents aged 13 to 17. If you have kids, you'll know what I'm talking about. Send or receive 3,339 texts a month, and that turns out to be 6 text messages per waking hour. Now, I can confirm this one. Again, I told you I have a daughter 20 years old, so young adults aged 18 to 24 send or receive about 1,630 text messages a month, and that turns out to be 3 text messages per waking hour. I'm guessing that may be a little more, but I'm just going on how many my daughter does, and I see her on her phone. So let's talk about confidentiality, or again, the lack of confidentiality when it comes to this new technology. Text messaging transmission process. So traditional short message services, also known as SMS text messaging, is non-secure and non-compliant with safety and privacy regulations under HIPAA. Messages containing EPHI can be read by anyone, forwarded to anyone, remain unencrypted on telecommunication provider servers, and stay forever on a sender's and receiver's phone. Good to know. Let's talk about your phone carrier in text message detail. For the sake of this conversation, we'll only talk about Verizon, T-Mobile, AT&T, and Sprint. Now, we all know there's hundreds, if not thousands, of cell phone carriers out there. We'll start with Verizon. The detail of a text message stays on Verizon for a year. T-Mobile, 2 years prepaid, 5 years postpaid. AT&T, which I have, 5 to 7 years. The message detail remains in Sprint, 1.5 to 2 years. Now, the message content on Verizon, 3 to 5 days. T-Mobile, AT&T, and Sprint, the message content doesn't even stay on for a single day. And finally, the call detail records, Verizon, is 1 year. T-Mobile, 2 years for those prepaid accounts and 5 years for postpaid. AT&T, 5 to 7 years, and Sprint, 1.5 to 2 years. So again, going back to A&E series, the first 48, this is why police officers love phone records. To ensure the patient's privacy, clinicians should consider the use of encrypted email systems or portal messaging systems that can be used by a computer, a tablet, or a cell phone. And now I'm going to turn it back over to Susan, who's going to talk a little about, amongst other things, patient Googling.
Thank you, Dean and Lisa. We have to talk about unintentional disclosure. When you're sitting in a coffee shop or another public area, perhaps a mall, food court, and you have your laptop open or your phone open, you have to realize that you could be transmitting or be seen to have information that should be kept confidential. Please be aware. Our opinion is that engaging, friending, and following those we serve, supervise, teach, or collect research data from crosses inappropriate boundary lines because it implies a personal relationship. The point of this slide is it appropriate to friend a client? And our opinion is that it is not appropriate to friend a client. It crosses the boundaries of personal and professional relationship, and it puts the clinician out there for ethical dilemmas, and it does not protect our clients. The accessibility and anonymity and universality of the internet have made it easier and more tempting to Google clients. Should a counselor, clinician, or social worker Google a client? It would depend on the motivation of the Googling. If the client was at risk of danger, perhaps yes. Otherwise, to Google a client to find out personal information, something that you're not aware of beforehand, it is not appropriate, and you'd have to wonder what the motivation is on behalf of the clinician. And is there a signed release? And if you learned information that you did not know about, it should it be documented in the chart?
Also, Susan,
Yes.
This would be something that a staff member, a CASAC, should speak to their supervisor about prior.
Of course, and in supervision. And the agency should have policies and procedures where if a client should be, what the reason would be for Googling a client. Perhaps the client's safety was in question. That would probably most likely be the only time a patient would be Googled, if it was a client was at risk for safety.
Thank you, Susan. Thank you for the clarification.
You're welcome. Now, 3 things to consider before conducting patient-targeted Googling. What's the intention of the search? What is the reason for the search? What is the risk to the client? It needs to be evaluated. And what would you do with gaining previously unknown information? Is it necessary for the treatment of the client? Most likely not. So these are the things to consider before conducting patient-targeted Googling. Now, Timony emphasized the need for organizations to develop media policy and procedure and provide staff with guidance and monitoring when it comes to this area. These are the additional rules to be considered. Don't endorse as a matter of course. Supervisors, don't initiate an employee friend request at your own behest. Separate your circle of friends from patients you mend. Corporate logo in your username is a no-go. Adding a disclaimer is probably saner. Don't practice on the internet regardless of your good intent. Always surmise that HIPAA applies. Speak on your behalf, not that of staff. Anonymity is really gimmicky. And if you chat about your company, identify abundantly. More in-depth questions when you're thinking about searching. Why do I want to conduct this search? Would my search advance or compromise the treatment? Should I obtain informed consent from the patient prior to searching? Should I share the results of the search with the patient? Should I document the findings of the search in the medical record? How do I monitor my motivations and the ongoing risk-benefit profile of searching? Very important. Now, as we all know, with the click of a mouse, clients can find a wealth of information on their counselors or about their psychologists online. Sometimes the client's just searching for reviews of the counselor or psychologist. Other times, perhaps they're doing a Google search and there are no laws protecting counselors or clinicians from Google searches on behalf of clients. And everyone has information out there about them. Now, some personal information about the clinician may be available without knowledge or approval. That's why it is highly recommended by Lannon and Scott that people Google their own name and see what comes up, whether it be a personal address, personal interest, maybe a litigation, could be anything. So it's recommended that you Google your information and know what's out there about you. Assume that patients know a good deal about you because your private life is not beyond reach of the patient. And as we all know, anyone can Google anyone or anything. And it's a good idea to be prepared if a client says to you, I Googled you and this is what I found out. It's recommended to have your response ready for that and not to be blindsided by that. And have a response such as, I really respect my privacy as I respect your privacy, and I hope you'll adhere to that. Now, a final suggestion. Have these and related discussions during your supervision with your supervisor. How do you respond if a client tells you that he has Googled you? Read your blog, visit your website, know what's out there about you. Is there something that you really would be upset about if someone knew? Determine how to handle that. Can and how will you respond to comments or ratings posted on internet sites about you or your agency? How will you handle any negativity? It happens. People have things they say, and as we stated, anyone can post anything on a social network site. And with that, I would like to turn you over to my colleague, Dean.
I want to thank Susan and Lisa for joining me for today's program. I hope you'll find it useful while assisting clients in need of services. Your feedback is important to us. It helps us know we are meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Thank you again for joining us.